Hi, Alicia. How are you?
Sarah, I'm doing well. How are you?
I'm good. Thanks for joining us last night and tonight.
Yeah, my pleasure. It's a fantastic program. I am so amazed and grateful and
Oh,
just you guys are doing awesome work.
oh, thank you. Thank you.
Hopefully it spreads like wildfire. We need it just everywhere. So
That would be that would be good. I will tell you, like the way that we're funded is it's a state contract. So it has to start, with some kind of federal support.
uh, it's it's insanely frustrating how in redunculously underfunded diabetes education is as a whole
Mm,
when you see how effective it is as
right.
really the only treatment regimen for diabetes.
Mhm. Right.
Especially when you consider that the alternative is full disability, which
Mm,
is extraordinarily expensive.
yeah.
Um, but
Yeah. That's very true. Very true.
it's I have a patient who's actually on a program. They're out in Wisconsin, and it's a massive grant funded program that provides. It's designed to provide access to get kids into schools, and any kids with disabilities. And the parents just kind of read it and were creative with how they read the grant. Because one would typically read the grant and interpret it that it is to help get kids, wheelchairs, or because it's basically accessibility is how it's kind of
Uh,
worded. And the
yeah.
parents were just really open-minded and read it as they read accessibility, and they were like, well, diabetes education is what is going to provide our child the
Nice.
accessibility to be in public schools.
Yeah. And
And so the
independent.
grant covers their education. So
That's awesome.
yeah.
Um, so something that's new too. Have you heard of Blue Circle Health?
Yes.
Yeah. So that started in Delaware on November 1st, and
Yeah.
for type 1 adults, and that's just,
Yeah.
I mean, that's a remarkable program too.
Yeah, we partner with them for as basically as a referral source, because like they can't work with pregnancy, they can't work with peds and stuff like that.
Mhm.
So it's a referral source for them to be able to not just say, well, we can't work with you, drop the ball.
Right.
But wow, yes, I'm so excited about that program. I'm bummed that they can only work with people for like 6 months,
Yeah,
but 6 months is better than nothing. So
absolutely. And hopefully in
very
that six
excited.
months, the patient gets, on a trajectory and the resources they need locally.
Yeah. And also a lot of times we don't know what we don't know.
Right.
So just having that eye opening of like, oh, there's more. Like, oh, I can get kind of my appetite wet and
Right.
then get that stimulus moving. So
Mhm. Well, hi, Jan.
Hey,
How are you?
it's great to meet you.
You too. Thank you so much for joining us.
Yeah, I'm so excited to be here with you all tonight.
Good. Since you didn't join us last night, this is my daughter, Joey.
Hi, Joey.
She made a guest appearance last night too.
Aw. That's just one of the best things about Zoom, isn't it?
Yeah.
It really is.
Yes. Yes. As long as they're being peaceful.
Yeah. I've seen a lot of things. My college has been using Zoom long before the pandemic. We have two campuses. And so our satellite campus is 200 miles away down in Mobile, Alabama, which is on the Gulf of America, the Gulf of
Yes.
Mexico. Anyway, um, so we've been using it for a long time, and I've been doing motivational interviewing trainings via Zoom for a really long time. I mean, probably going back to 2017. And most people weren't used to it before the pandemic. So I was having to do all this teaching and training about how to use Zoom with me in that training. And inevitably, there were some really unusual experiences because people didn't realize that, their dad had gotten out of the shower behind them and walked to the kitchen sink with a towel wrapped around him. And, they didn't
Yeah.
realize those things actually happened.
Right. Like that guy that was on like BBC or something on the news, remember? And his kids walked in and the mom like freaked out. She came in and get him.
Oh, goodness.
That's the way to
Yeah.
put it. So Jan, how do you say your last name?
It's 3 syllables. Kavook, like book, Jin, like gin and tonic.
Kavookjian?
Yeah, that's great.
Okay.
Yeah.
Dr. Kavookjian. Okay.
Oh, that's great. Just don't pronounce it Kavookjian.
Yeah. I won't do that.
I get that a lot. The other one that will really throw me off is Kardashian.
Oh, yeah. You could take that as a compliment, maybe.
Well, I don't know. They're both Armenian. I'm half Armenian.
Okay.
And so anyway, so some Armenians, I don't agree with the way they live their lives, but
Yeah. Understood.
Yeah. Anyway, so Alicia, I see that you're a CDCES BC-ADM. That's awesome.
Yep. Going on 8 years now. So
Oh, that's great.
yeah.
And you must be the other speaker in this session
Yep.
tonight. Okay.
Yes, I've got
Yeah,
the 7:30.
Yeah, she'll speak
Okay.
after you.
Yeah.
All right.
The way we'll start is I run through a few slides and kind of go over the night's program, and then I'll do an intro for Jan, and then I'll also do Alicia's intro, so that when I'm done, Jan, you can go right into yours. I'll come back to help with your Q&A, and then Alicia can just go right into hers.
Okay.
And I'm fine staying a little late for any wrap-up Q&A if anybody's got kind of any lingering anything from the 2 days.
Cool.
Hopefully we have school tomorrow. So
But might not.
I'm
Is
fine
there-
with my little guy getting to bed a little late tonight if he needs to, because
Yeah.
he has a doctor's appointment tomorrow morning, so we're sleeping in anyway.
Remind me where you live?
I'm in PA, about an hour west of Philly.
Oh, okay. Yeah. So you guys got snow and ice today, didn't you?
Yeah, we had a pretty nasty morning, so they canceled school, but it looks like as long as we don't have any refreeze, we'll be good for tomorrow.
Gotcha. Well, that's good. So an hour west of Philly. So I went to Immaculata
Oh yeah.
on the main line there in
Yep.
Malvern. So
Yep.
are you close to Malvern, Exton area, or?
Yeah, I'm 20 minutes from Malvern. I'm in Thorndale, so I'm the very end of the line.
Nice.
Yep. I specifically moved because I work with Gary Shiner up in Wynwood. And my first 3 years with the company, I lived in Cecil County, Maryland. And so it was anywhere from an hour and a half to a 3-hour commute each way.
Oh my gosh.
And that was with an infant at home while completing my master's. It was just brutal. So when we moved, I gave my realtor the daunting challenge of I need to be within 20 minutes of the main line, of any of the mainline stations, in one of the following 3 school systems, and here's my price range. And he was like,
You want me to do what?
Yeah, he was like, that it doesn't exist.
Yeah.
But here we
Well,
go.
he obviously succeeded. Obviously succeeded.
Well, I want to say, kind of a little change of subject. I'm really impressed with how very organized that you all have been with this diabetes update.
Thank you.
Going back many months.
Yeah, well, thank you. That
way
is a
ahead.
testament to Amy. Yeah, she is. We found her a few years ago. Her son had type 1 or has type 1, and she reached out to us, and we have just held on to her, and she takes this under her wing and reaches out and finds you guys, and much better than I can, just because she's in the space and living it. So I'm very, very thankful for Amy. So Amy, if you're on, I hope you are. But she's helping us in. She's not on yet, but she's helping us with our Lions program too, that I'll give a brief overview here for you'll hear about. And she's a school nurse, so she's really been really helpful.
So just to be sure, as we're getting down here to the last few minutes, I just want to be sure that I got this right. You're going to give me the ability to share my slides after the intros and I'm getting started, right?
Yep,
Okay.
I will turn that on now so you both can share your
Okay.
slides. You should be able to do that.
And do you mind if I just give it a quick test now, just to be
Go
sure?
ahead. I'll stop.
Okay.
And then you should be able to.
You're able to see that, right?
Yep. There it is. If you put it into slideshow mode, just so we know that it's, yeah, perfect.
Okay. Okay.
Alicia, do you want to try yours as well?
Sure. I'll throw up a quick share. Share that one. And
Yep.
yay.
Perfect.
Stop.
And then Alicia and I will shut our cameras and mics off while you're presenting, Jan, just so you don't get any feedback or, my kid screaming for her PICCA when it comes out of the oven.
I feel like we really need to invent a filter that makes your screen not reflect off your own glasses while you're giving a presentation.
I see that.
My solution is I usually have a second screen when I'm in the office that I put my display on, but no such luck from home at this hour.
Yeah, I thought I was gonna do this from there, but I really have something I need to take care of after this. I need to get out and go run an errand for something tomorrow. So
Well, my vanity, I thought
just-
I'll just take my glasses off, and I'm entirely too aged for that. So
We got about 5 minutes.
Okay.
So Alicia, was it Anna that said she's worked with you?
yeah, we have 2 mental health providers that work with us at IDS, and Anna's one of those.
Nice.
Yeah. Anna and I partner up a lot. I'm actually going back to school this summer for my NP in psych.
Awesome.
As I think that'll be of more use in diabetes management than actually going back for endo or family practice, like most educators do. So Anna and I partner up quite a lot in our practice.
Awesome. Well, that was, I don't think we knew that when Amy reached out. So that's just a lovely coincidence.
Yeah. And I'm actually a little salty because half an hour from Elizabethtown, and she's presenting on March 8th in Elizabethtown. I'm presenting on March 8th in Jersey, like 2 hours from here.
Oh.
And then I'm presenting on March 22nd in Pittsburgh, like 5.5 hours away. I'm like, yeah. How come I didn't get the 45 minutes off my front step? That's
right.
Meanwhile, she's taking a plane to get to Elizabethtown. And I'm like,
come down.
We really did not coordinate any of this well.
Yeah. That's funny. All right, we're getting lots more people coming in now.
The attendance on this is fantastic.
Yes.
It's grown every year. I mean, we had 275-ish pre-register, but we had 215 like attend live last night. So that was really, that was a record for us by far.
Are they
That's
all school
awesome.
nurses, or do you get a lot of additional support staff, or?
It's mainly nurses, whether they're school nurses or like regular RNs in a different clinical setting. Then we also have CDCESs, and we actually opened it up to pharmacists as well. We offer all of those CEs, and then different groups will post it on like their different national sites. And so we actually got a large group from Minneapolis of school nurses
Yeah.
to join.
It would be fantastic information too for like school therapists and those kinds of support personnel too.
Mhm. Yeah, I'm not sure if like they can join. Anyone is welcome to join. If they want CEs, I get them through the ADCES, so it's unlimited to whatever they can offer me, you know.
Yeah.
We got 1 minute. People are coming in here. Okay, right on 6:30. So welcome everybody. I'm happy to have you back for night 2. I am Sarah Bloom, the Executive Director of the Delaware Diabetes Coalition, and you are here for the 5th Annual Virtual Diabetes Symposium, Day 2. Also, Kimmy Moore is our president, and
wow, pizza.
I'm sorry, pizza just arrived. Okay. I saw the Q&A here. I did send evaluations for last night. I sent them this morning before 12 o'clock. If you did not receive that email, please send me an email so I can make sure that I have record that you attended last night and that you'll get to see the CE or the eval so that you can get the CEs. So who we are, we're a coalition of healthcare, a nonprofit organization comprised of a network of healthcare organizations throughout the state. We work together to improve the lives of all Delawareans living with diabetes through advocacy, awareness, education, and events like this, as well as our annual Wellness Expo every National Diabetes Month in November. A program that we do is the college scholarship, and that's actually how this event was kind of birthed out of the idea that we don't get a lot of applicants, and so we wanted to reach the audience that's talking to the available our available applicants, which is type 1 and type 2 patients. They have to be a Delaware graduate, so it can be a senior or even someone that's in college. But as long as they have a Delaware residency, they are eligible to apply. We give $1,000 scholarship annually. The application is due April 30th. Please continue to spread the word because we have seen an uptick in applicants. Last year, I think we had 7. So that's, we're definitely doing better. A new program that we introduced to you guys last year, it went live in March. It's a partnership between the coalition, the Department of Education, and the Lions Club of Delaware. It is a free 3-level diabetes training for all Delaware schools. So I know I have a lot of Minneapolis school nurses on here. I apologize, this isn't available to you. But as long as you are a Delaware school nurse, teacher, coach, bus driver, contractor, or parent, you are welcome to take this course. There are 6 free CEs available to the nursing community. And so you can access that through that website or the QR code. I'll also include it in my follow-up emails. As of January 31st, we've had 249 people enrolled. That's 161 of them were school nurses. And of our 266 school sites in the state, 135 are actively participating. Amy Hastings is our nurse facilitator there. So if you do have questions, that's her email. She can certainly help you get set up. And just a growth graph on that. So every spring we get new modules. So you can actually take this twice at this point. You can take it right now and get 6 CEs. And then when we get new modules in the spring, you can take it again and get 6 more CEs. So between tonight and those 12 CEs, the coalition is offering up 16 CEs to all of our school nurses. For this evening, to receive continuing ed credits, you have to watch the full 120-minute webinar live, complete the evaluation by March 1st. You'll get 2 credit hours for tonight, 2 if you attended last night in any of that criteria there. Speaker disclosures and the full accreditation statements are available on our website. The learning outcome for this evening or for the event is attendees will report an increased knowledge of the school nurse's role, managing the mental load of diabetes, relationship building, navigating difficult conversations, and care coordination. And finally, tonight's agenda, starting here at 6:30, we're going to have Jan Kavookjian. Did I say it? Kavookjian? Correctly?
Yeah.
Sorry, Dr. Kavookjian. Motivational interviewing for school nurses, building relationships and navigating difficult conversations. And then following at 7:30, we're going to have Alicia Downs talking about care coordination, supporting students with diabetes. So give a brief, some introductions here. Dr. Kavookjian is a faculty in Outcomes Research Department at Auburn University in Alabama. She's a researcher, speaker, author with a primary focus in behavioral science applied to chronic disease management and prevention. Most of her research has been conducted in diabetes. Her evidence-based motivational interviewing practitioner training spans across 3,000 practitioners, over 3,000 PharmD and PhD students, and 25 years. The training model was recently revised to lay level for parents of type 1 youth, and she was invited by the CDC to lead a panel of experts in a national webinar for motivational interview in diabetes care. So following that, we will have Alicia Downs, and Alicia's diverse nursing career has given her experience with a broad range of clients and a variety of health conditions in addition to diabetes. One of her passions is advocating for the needs of her patients, whether it be in overcoming insurance restrictions, obtaining community resources, or coordinating with school systems and medical providers. So with that, I'm going to turn it over to Dr. Kavookjian, and I will stop sharing my screen so she can share hers, and we'll get the evening started.
Okay, I'm just going to say a few words before I pull up the slides, just to greet you all and let you know how excited I am to be here with you this evening. If you reach out to me, please just call me Jan. I got my degrees here at Auburn, had my first faculty position at West Virginia University, and then I got recruited back. I've been here almost 20 years. And my walk with motivational interviewing actually was built while I was raising my 3 children by myself and getting my PhD. I know that sounds insane. And so I really learned so much during that time, that really very challenging time with 3 kids who became teenagers, one of whom has a real serious chronic disease, not diabetes related. And so there was a lot of, I felt very much like I could relate to parents who I met in the studies that I did in developing and validating the motivational interviewing training for parents of kids, primarily adolescents with type 1. And so I did that study. I got some funding, developed this very high level technical training for healthcare providers into a lay level user-friendly training and materials for parents of type 1, and just really had an incredibly rewarding experience is the favorite thing that I do in my professional life. And I've really partnered a lot with the organization known as Children with Diabetes. You may be familiar. They have their Friends for Life conference, and I've been there twice. I've been invited back again this July to deliver that again, and I feel really really blessed to have the opportunity to just disseminate this work that I have developed in this space, because I know how hard it is to be a parent with adolescents, especially with the one that had the chronic illness, and trying to navigate that with everything else going on. Now, I realize that you all are primarily school nurses, although not all of you are, and I've developed the slides around conversations, primarily conversations with kids or with parents. But all of this translates beyond this context. So if you have not been exposed to motivational interviewing, or MI, as I'm going to call it for short, and that this is really not your field as school nursing, there's a lot here for you as well. And what I want you to know too is that in research that I've done with that, and then some subsequent things in adolescent perceptions of stigma among children with type 1, is that in both the parent report and the adolescent report of where their important social support sources come from, especially in the parent study that we did, the school nurse was like the top or second only to the spouse source of social support for the parents. And in my own family, my own extended family, I have a young child with type 1, and those parents are telling me the same thing. So I really commend everything that you're doing. I'm delighted to be here with you today to share this with you. And so I am coming to you from Auburn, Alabama, but I came to Auburn, Alabama from Dover, Delaware. I graduated from high school at the former Dover Air Force Base High School. My dad was a C-5 pilot. So if you're from Dover, I know you know what I'm talking about. If you haven't seen one, I know you've heard it. But I'm really excited to be here with you all. Delaware is like my one of my places of roots, and I'm just so thrilled to be able to share some things with you today. So let me go ahead and pull up my slides, and we'll get started with the content that we have today. So disclosures, I'm not going to read these to you. We're just required to include those. If you want to know more about those, I think she said there's a place where you can find more information about that. But we also do have some learning objectives. And again, in the interest of time, if you know MI, you know it's going to be really difficult to do this in about an hour, a little less than an hour. And what I want you to know is that I have actually created, I've got some objectives I'm trying to accomplish here, and it's really all about awareness raising. I don't know your level of exposure to MI before, but I'm going to guess, based on other audiences that I've presented to, that there are some people for whom this may be their first exposure to it. But probably a lot of you, knowing what I know about nurses and CDCESs, really have immersed in MI, and it's what brought me to ADCES and the national elected leadership role that I had there a few years ago. So awareness raising about positive and negative communication trends that are happening in healthcare related conversations. Again, I've already talked about the audience assumptions. I'm going to do a motivational interviewing overview for concepts, but I really am also hoping that you will get the slides, keep them as a resource, because I put a pretty comprehensive coverage of the MI toolbox, as I'll call it, but I don't have time to go deep into everything that's there. I've put it here, not going to go over it all, but I wanted you to have that as a resource. We're going to hone in on a few very specific and very important aspects of MI and look at those in example little pieces of a dialogue along the way. And then I also have posted a couple of other resources that I freely share, and I really hope you'll download those. I think she was making those available. One is the MI summary. It's actually the parent version, so it's somewhat in this context. just a quick 6-page, summary of MI and the overview. And then also a little worksheet that is usually one of the first activities that I'll do if I'm doing a training. I had a lot of healthcare providers tell me, I don't know what to say first. When somebody says something unusual to me, I'm not sure what to say first. So I will usually either change the subject or I will end the conversation and walk away because I don't know what to say first. So the very first exercise that I will engage is, what would that first response look like? And am I consistent in the way you deliver that first response? So I'm going to show you some things along the way as we go through the content that would give you an idea of what might be some good first responses. And then that worksheet is just some unusual statements that someone might make, particularly an adolescent, and then some blank space for you to take that and kind of work with that on your own and have that experience. So I am not going to spend time going over the context here. I think I'm preaching to the choir. I think you all are probably pretty aware of what's going on with persons with diabetes in general, and particularly adolescents. And I know that Alicia, who's coming after me, is going to go pretty deep with that. So I'm not going to linger here, except to just really emphasize that self-management is complicated, but even more so with adolescents with type 1, as you can imagine. These are people in development, and they are going to require adult assistance for learning lifelong skills that are just about as important in functioning and succeeding in life as reading and writing and math. And we would never want to discount, the importance of that. So parent or other adult interactions about diabetes with these adolescents can be the most positive or the most negative influences on empowering self-management in adolescence. And that can be true with, adult to adult conversations as well. I think if you think about your own world and any health behaviors that you need to be engaging in that you're not currently doing, you would agree with me that at least one or more or all of these represent barriers, things that get in the way that make it hard to actually make a change. We don't have time to go deep here either. We could spend a whole week on each one of these bullets. You may also be in a situation where you're complicated by what I call practical barriers, just simply literacy level, cost, access, preferences. These adolescents are dependent on their parents for getting what they need for their management of their type 1. And so just a whole lot of other things that go beyond what's going on inside of that individual in terms of thoughts and feelings. So I want to just kind of start with this quote. This quote is a quote from the MI originators. This is Miller and Rolnick and their colleague Butler and their book, Motivational Interviewing in Healthcare. Great book. I could talk about that at length. It's a really nice, user-friendly paperback, and because it's been around a while, it's pretty inexpensive to acquire in your favorite places that you might acquire that. But it's a really good starter book. It's very user-friendly, and Miller and Rolnick come from psychology. They are counseling and addictions fields. So for them to translate what they were doing there in addictions, alcohol, smoking, substance use disorder, into the healthcare arena, really, this was a pretty good job they did. Not perfect, but pretty good. Anyway, in the beginning of that book, they're making the case for motivational interviewing. Miller himself makes this quote: "We tend to believe what we hear ourselves say." And it seems like a really simple statement, but it has a lot of science behind it. It's backed by a couple of really powerful evidence-based behavior theories that have stood the test of time. The primary one is self-perception theory, and the secondary one is self-determination theory. So I'm not here to talk about those, but I do want you to know there's science behind what Miller is saying here. And the premise behind this is really what motivational interviewing is all about. So we tend to believe what we hear ourselves say means that if I hear myself talk about making the change, so for example, if I was talking about getting more activity into my routine, and I were to say to you, I've gained some weight and I know that my numbers are creeping towards the pre-diabetes range, and I have type 2 diabetes in my family. And I feel better when I am not carrying more weight. Then when I say those things and I hear myself say it, I feel this urge welling up inside of me. This is internal motivation. It really is often a palpable feeling. You can actually feel it emerge. Okay, the opposite of what I just demonstrated is also true. If I then say to you, but, all those reasons why I know that I should, but I am so busy. I have got so many responsibilities in my, 10 or 11-hour workday, and responsibilities at home after that. I'm often bringing home work on the weekends. And anyway, as I'm telling you all the reasons why not, I feel that urge deflate. So think about what I said. We tend to believe what we hear ourselves say. So the entire premise behind motivational interviewing is not, you often hear, I'm going to use MI to motivate somebody. I'm going to use MI to get that person to take their meds or check their blood sugar. And that's not accurate. That's actually contradictory to what MI is all about. It's about interviewing the person in a way that they end up hearing themselves make the argument for making that change. So this is a really important part. It's about interviewing so they can get to their own internal motivations for making that change. And this is a very, very powerful thing, because when we hear us talk about our own motivations, instead of somebody finger wagging and saying you need to and you should, then even goal setting, setting my own goal about how that's going to work for me, instead of somebody saying to me, get up early and start walking, or do it on your lunch hour. But somebody saying to me, what would be a good goal for you to set for yourself for getting just a little more activity into your routine? And then I come up with something. Science behind goal setting says the same thing. I am much more likely to engage it, at least to attempt it. And certainly if I sustain it, if I have heard myself say it and set that goal. So a key here is that we all have to have our own internal motivation for change to happen, and also for it to stick. We have been studying motivation in the behavior sciences space for decades. I would say probably 60 or 70 years, or maybe more than that even. We have been studying that for decades, and the science says that internal motivation is the type that will stick. Whereas what's happening in healthcare a lot is a external push or a pull. A push or a pull to temporary change. That's external motivation. But if somebody's really not ready to change and they're just changing to please you in the moment, it's not likely to last once the source of that motivation, your push or pull, is not following them around in their daily routine. So that push or pull has a name. And in the MI realm, we call it the writing reflex. And you may or may not have heard about the writing reflex before, but humans really do have a natural tendency to want to help or fix what's wrong with others we care about. And this is especially true in health professions. Most people who choose a career in the health professions really want to help. It's very well intended, this writing reflex. It's very well intended. It says, I want to help you. I'm in your corner. I want to give you my expertise and the things that I've learned along the way so that I can help you. And it's not that you wouldn't use your writing reflex. It's the way you deliver it. So the push or the pull is the problematic version of the writing reflex. But the interviewing in a way that someone else is coming up with the ideas or setting the goal for themselves is what really matters. And the thing is that this writing reflex, if delivered in that non-productive way, it really can do more harm than good. It's been shown that if people get defensive and they start hearing themselves defend the reasons why not to make a change, then they are much less likely to actually be engaging in the behavior that we're hoping for, the behavior that's hopefully going to help them achieve the outcomes, excuse me, the outcomes that we're all hoping for. So key point, interview your child or that child or teen or whoever you're talking to, even if it's another adult or even the parent, to elicit or guide him or her to find and express his or her own internal motivating factors. This helps facilitate their own decision-making process. So there are some MI assumptions before we start looking at what some of the skills are that I would really want to start you with, and that is to know that really foundational is at the top of the list for a reason, is about building an ongoing relationship or trust. If you're a school nurse and you're going to have this child that you're working with all year, you want to go ahead and start from the beginning with developing good rapport and empowering communication with them to help build relationship and trust, so they will see you as that social support or that support person that they can turn to when they need help or have questions. Same thing if maybe you are a parent with a child with type 1 or another chronic condition, like in my case. And that trust factor is so very important. And we'll talk just a little bit about that as we go. So again, it's not about motivating, but it's helping them get at their own internal motivation. So what we're hoping to do here is empower that adolescent to experience how to make good choices. And all of this with successes in this and with empowering them and with putting the ball in their court to a degree, and I will talk about that, really helps build self-esteem and confidence in their own world, and especially in self-management of type 1. So spirit of MI, that is what we call the relational dimension of motivational interviewing. And it's a really important factor to just really kind of touch on here, because motivational interviewing has some skills, the technical dimension. We're going to look at some of those, but it also has an approach. This is about the way of being that's known as the spirit of MI, and it is characterized by the bullets that you see listed on this slide. And if you look at the bullet at the bottom, it really does require practice over time and just really a mindful intention for most of us to decide to go into this encounter with a sense that I'm going to collaborate. I'm not going to take this over. I'm not going to become advising and fixing. I'm going to collaborate and have a conversation where we can problem solve together to empower, but also to be caring and non-judgmental, to be person-centered, meaning focusing on what's important to this person and to what's important to this person today, because you probably know, if you think about your own self, and if you even think about others that you have encountered either in your professional or personal life, I might have preferences today that I don't have tomorrow. So when you're having this conversation today, if you're really being person-centered, you're coming in with this active listening about where the individual is today and what they're feeling today. Really, where are they today? And we get at that by evoking or eliciting ideas before giving your own ideas, ideas about how to make these changes, about what kind of goals to set, and so on. It's also about deciding to support their autonomy and support their self-efficacy. We want to praise even when we hear them talking about changing. You've probably heard about positive reinforcement for the behaviors that we want to see exhibited and how much more powerful that is than shaming or punishing for the negative behaviors that we're hoping kids are going to extinguish. So really being positive and encouraging is a really big part of motivational interviewing, especially with this age group. So there are some principles, and I'm just going to hone real briefly into these. We've got expressing early empathy. This is about listening and caring, developing awareness of differences. This is also known in the healthcare arena as developing discrepancy, avoiding arguing, rolling with resistance, and then supporting confidence and praising successes. So let's take a look at expressing empathy. What do we mean by that? It's not sympathy. It's not, I'm sorry. It's not, I understand. Miller himself has said this prevails, and I personally have seen it in probably about 2/3 of it's now about 33 or 3,400 healthcare providers that I've trained. I've heard that I understand piece, which is very well intended, but it can feel patronizing. And so We're encouraged not to use I statements when we're trying to empathize. It's just reflecting back what you hear that person expressing about the feelings they have. They might tell you exactly how they're feeling, or you might read between the lines and tell by their verbal and nonverbal expressions about what they're feeling. I'm going to show you some examples in just a moment. Just lets them know you're trying to understand, and it doesn't mean that you agree or enable because you're reflecting back a feeling to them. It just lets them know you're respecting them where they are, and it builds support and security because you're not going to argue them down from where they are. And that's a really very important point. So here's an example. This is James. And he says, I just don't know if I can do all this. Okay, we really don't know what he means by that. There's a temptation to say, why not? Caution about why. The why word is an interrogation word. I encourage you to put it in the bucket with closed-ended questions and try to take it out of your vocabulary. When we use why, people think you are setting them up to argue them down, and a lot of times they'll get defensive. And again, if we hear ourselves defend why not, then it just reinforces not making the change. So instead, we're going to approach James with an exploratory, empathic manner. Now, what I also want you to know is good idea to start with calling James by his name. That gets his attention, lets him know he's at the center of your attention. James, you sound worried about all that you're being asked to do. So there's the empathy. You sound worried. And now, open-ended exploration. What concerns you most? That's, to me, one of the best open-ended questions ever. What concerns you most, or tell me more about that? These are two great open-ended exploratory questions when you want to explore a little bit further. And they can go a long way to diffusing someone who's really upset or really resistant or very contentious. What concerns you most says, I'm listening. And that can really help diffuse situations like that. So again, I call this early empathy because quite often the very most ideal first response after you hear someone either express a strong emotion or express something that lets you know they're very resistant, the early empathy, the very first response as an empathic statement can really be the most impactful. And so this is what I call early empathy followed by open-ended exploration, meaning an open-ended question, what concerns you most? Here's another example from Mary. Let me just kind of move, I can't see the text because I've got there we go. Mary says, I am so tired of these alarms buzzing in class and people staring at my sensor when I'm playing softball. I want to go off the CGM and go back to checking my sugar and injecting myself privately at school. And so Joe, this is Mary's dad, he says, Mary, you sound embarrassed, like being on a CGM is drawing the kind of attention you don't want. Tell me more about that. So that tell me more, there's the empathy, you sound embarrassed. Drawing the kind of attention you don't want. Very compassionate statement that says, I'm in your corner, I'm trying to understand, and then tell me more about that says, I want to collaborate and problem solve with you. Here's another example from Aaron, Aaron's mom, Kate. And I'm actually going to, in the interest of time, this is a third example. I'm going to keep moving, but this example is here. Kate, you sound overwhelmed and feel like you're doing most of the work. Tell me more about that. So here's another one, Mark. All kinds of examples here that are here for your benefit in this slide set that I'm hoping you're going to see as a resource. But in the interest of time, as I said, some things I'm just going to quickly go through because I want to get to this slide. I know I already said the bullet at the bottom, avoid, I understand how you feel. I think most people will take it the way in which you intend it, but some people will feel patronized by that. And I would speculate, especially if you're working with an adolescent who is particularly defensive, and I think we all know that adolescents are already by their very innate tendencies or instincts, they're already trying to establish their own independent personality. And so this is just part of life at that age. And so if you were to say, I understand how you feel, you might get you couldn't possibly understand how I feel. So I will tell you, among all these people that I've trained, probably about 5% are people for whom feeling empathically and accurately empathically responding is a natural way of responding. The rest of us, and I include myself in that, are really empathic people inside of ourselves. But like in my early days of learning empathy, this very important person-centered, standalone, vast evidence-based communication skill, the thing about this for me was I knew that I needed to respond empathically when I heard somebody express a strong emotion, but I really wasn't sure how to say that. So remember, I said I'm going to give you some little tips on how what do I say? I don't even know how to say. I don't know the first thing to say. So here are just some stems, because I'm kind of some response starters. You seem, or in other words, and then reflect back what they said. You feel frustrated because you're embarrassed by the noise the CGM is making, it seems to you, and so on and so forth. I find that conversationally, I just sort of naturally say either it sounds like or you sound. That's what typically just kind of emerged for me naturally. So I encourage you to kind of think about those. And if you're someone who is in development for the empathic responding part without using I statements or sympathy, I encourage you to think about these and others. And just a straightforward reflection is always a good choice. So there's another reason that I'm going to focus on the combined rolling with resistance, avoiding arguing. And again, because I think I told you up front that a lot of people I've trained have said that when they are met with resistance, somebody puts up a big wall and it's a confrontation, they don't know what to say next. And so quite often they will walk away, change the subject or end the conversation and walk away. So resistance is information. And if you train yourself to just roll with it and don't get drawn into it, even if somebody attacks you personally, and I think we all probably have had an experience at one time or another where either observing or in our own worlds that a teen in our world attacked us personally. And it's really tempted to get drawn into that, and they know how to push your buttons, right? Instead, pause and train yourself to roll around that and just stick with the topic at hand. And so I have developed these motivational interviewing consistent three approaches. So the first line approach is that example of expressing empathy and then open-ended exploration. The second one is to ask permission to share your concerns or your worries, and then give the information that you realize they need because there's a knowledge deficit or a big concern. And then if you get to the third level, meaning they're still resistant, to continue to push at that point within reason, as long as it's not like a medical emergency or a very critical factor, emphasizing personal choice. And I'm going to give you some examples of what that might look like. So now we're looking at, and let me just move the photos or the gallery is in my way to read this to you. So now we're looking at May, and this is James's mom. And so May is talking to her mother, and she says, "You need to quit bugging me about James's diabetes. He's only 13. There's a lot of time for him to get better with this. He's got type 1. So May's mother says, "It sounds like you're overwhelmed about James's diagnosis and not wanting to talk about this now. Tell me more about that." So again, not arguing with her, not getting drawn into the quit bugging me piece, just really, here we are with that. So they talk about it, and May says, "I just don't think it's that big of a deal. Our family members are having challenges of their own, so I'm not going to make all these changes for all my house because of this one thing with James." And so May's mother says, "May I tell you what concerns me? Or can I tell you what I'm worried about?" is also a good way to put it too, because it says, I care. It's not just asking for consent. May I give you some information about that? It's adding that extra caring component. Can I tell you what concerns me? And so she gives her the information, and May is still resistant. All that is such a hassle, and nobody else is going to like that food. I don't see how we can do it. So at this point, the worst thing that could happen is to push. No matter how MI consistent you are, if you continue to push when May is in this mood and is very resistant, the only thing that we can do is what Miller and Rolnick call emphasize personal choice. Here's an empowering place. And so May's mother says to May, and it really is your decision. All I can do is tell you the advantages and disadvantages of making small changes and give you my opinion, but it really is up to you to decide. And then I always encourage leaving the door open. So in this case, May might say, or May's mother might say, when you're ready to talk about even some small changes, let me know how I can help. So same thing if you're in a healthcare setting, maybe you're not a school nurse, maybe you're in a healthcare setting and you're talking to other patients. I think this is really important to leave the door open if you're going to emphasize personal choice. This is really hard to walk away like that, but if you continue to push, you're going to put the person on the defensive. You're going to not only reinforce for them why not to change, but it's also going to strain the trust and the relationship between you because they're going to feel violated. So I just encourage you to think about that and think about these examples in your professional world, in your families, or if you are a school nurse. Now, I will tell you that caveat here is that, sometimes if you're a parent or you're the school nurse, you're just going to have to put on your coach or facilitator hat. And I encourage you to use that language with adolescents. When first time you meet with them, let them know, it may not even be adolescents, it may be younger kids. Let them know, hey, I am your support person here while you're at school, and I want to collaborate with you. We're going to partner in this so that you'll be feeling good most of the time. And sometimes, I'm supposed to be your coach, and I'm going to have to put on my coach or facilitator hat, and I'm going to have to step in and make some decisions for your best interest. But most of the time, I really want to partner with you. So that would be something you could say up front to establish the relationship. So I also just really want to tell you about, praising. This is really very important, this reinforcement piece. Even if they talk about thinking about making changes or attempts that they've done in the past, that's great that you're thinking about. Let me just show you some examples. Mary, it's great that you manage your diabetes every day the way you planned. Or you're well on your way to better health since you're even thinking about finding ways to get some activity into your routine, James. Erin, that's great that your A1C has come down since last time. Tell me about the things you're doing that are helping you succeed. Kate, this is Erin's mom. She's talking to Jack, her husband, Erin's dad, or maybe not even husband, Erin's dad. Jack, that's great that you're thinking about finding ways to support Erin's decision-making about how to cut back on sweets she eats in a day. So really using it also among yourselves as well. So another piece that I really want to emphasize here is that confidence can really be built by not making this all or none changes. So if you're talking to an adolescent about all or none changes, and I'm not talking about insulin use, obviously, but if we're talking about lifestyle behaviors, big words like diet and exercise are ideally, or even quitting if you're talking to somebody about smoking, are ideally left out of the conversation, especially if you're in the early stages of getting to know this person and they're already resistant or really discouraged. If you talk about diet and exercise, think about it. If I were to ask you, what do you think about when I say diet? You think big change. I've got to go to the store. I've got to make plans. It's a lot of effort. It's disruptive. If I ask you to think about exercise, you're thinking gym, equipment, going to sweat. It's going to be hard. It's going to be a lot. And people will automatically, oh, excuse me. People will automatically just put up a wall in the face of that. So instead, use language like you see in the bullet at the bottom, small changes to some of the foods you eat, getting more activity into your routine, cutting back on number of cigarettes, and so on. This can be very encouraging because the premise is that if people have success in little changes, then this can progressively build confidence towards making bigger changes towards the level that we would be hoping for and trying to impact outcomes. So, what about strategies to help confidence in building self-management, to build independence and self-management? And so there are a few things that I'd like to highlight for you. There are a lot of other things we could talk about, but I really just have just a little bit more time to focus on a few things. And open-ended questions are really very important with this age group. They're autonomy supporting, they're empowering. And if you just were to say things like, have you thought about this? Did you try this? Did you get the right timing today and injecting the insulin before lunch? Did you get the right timing? So there's a right and a wrong answer there. And people will get defensive. What if the answer isn't yes, like you're hoping? It's actually no. They're going to either want to be dishonest with you, or they're going to be honest, but then they're going to feel dissonance. They're going to feel judged. So instead, a couple of open-ended stems that are useful. And in fact, if you look at the MI summary that I gave you, there are lots of examples there of open-ended questions. But what I have found is that when you are trying to assess their readiness or willingness to engage in something, what are your thoughts about, or how would you feel about, are two great open-ended question stems. I encourage you to jot those down for ways that you can help someone express where they are in that. It's not an all or none. It's not a yes or no. What are your thoughts about, or how would you feel about? And then the second strategy is a hallmark of motivational interviewing. It's about permission asking before giving advice or information. Now, what I'm talking about here is talking about knowledge gain or self-management behaviors. It may not even be self-management behaviors. It may be other things like keeping their curfew, or substance use or alcohol use if you're talking to adolescents who are getting behind the wheel of a vehicle. So the permission asking says we're collaborating, and you can always preface it by something like, I'd like to tell you what I heard that other kids have said worked for them for whatever that target behavior is. Okay? So there's the permission, the okay, or do you mind if I make a suggestion, is the one that I still to this day use. In fact, my kids make fun of me now. They're in their 30s, 40 in about a month for one. They make fun of me about this. I'll say, do you mind if I make a suggestion, even to this day? And they just kind of laugh because they know what I'm doing. But the third one I really want to show you, this is agenda setting. This is one of my favorite pieces of motivational interviewing because it accomplishes so many great things. And oh, I forgot that I had this. So I forgot that I had examples. I thought that was my slide for those. So anyway, here are the examples for some open-ended questions for autonomy support. But what I really want to get to is the agenda setting piece. So this is where you can offer choices about what they want to talk about first among a sequence of topics that you know you need to talk about. So here's an example. To help keep you from being readmitted to the hospital, Erin, we can talk about small changes you can make in the foods you eat, getting more activity to your daily routine, and insulin use. Which of these would you like to talk about first? So she feels empowered, not violated, because you're giving her a choice. This is a very powerful strategy in that regard. She picks insulin, you talk about that, how that's going, and any goal setting that you think needs to happen there, or that she agrees needs to happen there. And you would say, what would be a good goal for you to set for whatever the challenge is in that? And when will you start? You're asking for the commitment, and she's going to hear it come out of her own mouth, and it's going to be more likely that she'll actually do it. Now that we've talked about the insulin, which of the other two topics would you like to talk about next? Another thing I really love about this strategy is you can insert into the middle of that list contentious subjects like maybe smoking or alcohol intake or sleep. Maybe you've had challenges with sleep, or other behaviors, keeping curfew, getting homework done, whatever that might be. Or here's a couple of other examples that are a little more simple for agenda setting. And since we only have 5 minutes, or maybe we only have 5 minutes left, and I would imagine a busy school nurse really might need to occasionally set a expectation like that. It's a lot easier to end that conversation if you've told them up front, since we only have 5 minutes, then, and this is if you just really know that you need to keep it limited, saying that up front. So since we only have 5 minutes, we can probably talk about one or two topics for healthy activities. Which would you like to talk about first? Or Mary, your doctor asked me to talk with you about things are going with your insulin, but I want to be sure to address your top diabetes concerns first. So which topic would you like to talk about first? So these accomplish so many things. They really set some expectations. It gives you an opportunity to be a little directive at the same, with what you're going to talk about. If you need to be, at the same time, you're supporting autonomy and not violating autonomy. So you're more likely to feel like you're collaborating. So just real quickly, I also want to point you in the direction of eliciting change talk. This is about helping them talk about the change so that they can hear themselves talk about making the change, benefits, what's your vision or goal for what your life with diabetes will be like in the future. These are just quite a few examples, and I've got some additional ones, desirability, reason, and need. These are the darn types of change talk, and here's some more example questions for helping find ways to get them to start talking about positive things about whatever that target behavior is that you're hoping changes will happen with. And then there's the readiness ruler. So you might say how on a scale of 1 to 10, with one being not at all and 10 being completely important, to anchor it. It might be how ready are you, or it might be how important would it be to you, or how confident or how willing. How, in this case, how ready are you to help your diabetes by cutting down on the number of Dr. Sugar drinks you have each day? And so James says a 7. And so this first follow-up question is really very important because this is the one that elicits the change talk, the motivators. Okay, a 7, that's great. There's the praise. Now, why a 7 and not the minimum, a 1? So what he's going to tell you is what his motivators are, and he's going to hear himself say that. And then the second follow-up question is also pretty useful there as well. So just a few final quick highlights of some additional things I want to share with you about person-centered communication with no matter who it is, adolescent or adult, whoever it is, whether it's your professional life or your personal life. It's really important to be direct and honest. This sends a subtle and even subliminal perception of honesty and credibility, and that builds trust. So James, your 9A1C is a little high. So I've heard this in probably at least 2/3 of the practitioners that I've trained. And it's something that a lot of us do. This is something that I actually had the habit of doing in the past as well, till I became aware of it. A lot of us do this because we want to cushion the blow. We want to minimize the confrontation of delivering this information. But instead, if you're appropriately assertive, put a caring and conversational, matter-of-fact tone in your voice and say something like this. James, your A1C is 9 and this is high. The research studies say, or the guidelines say, keeping it below 7 is a way you can reduce your risk of diabetes getting worse and making you uncomfortable. What are your thoughts about that? So what are your thoughts about that is a hallmark of motivational interviewing. It is finishing out the giving of information by putting the ball back in their court and letting them know we're having a conversation, we're collaborating. I didn't just say that, to manipulate a change out of you. So here's another thing with kids. I see a lot of parents using this frame for trying to discuss something. James, it's time to check your blood sugar, okay? So that's again, because James, it's time to check your blood sugar sounds confrontational, and most of us don't like confrontation. Then we'll put the okay and the question mark to soften that. So instead, just in a very matter-of-fact, caring voice, James, it's time to check your blood sugar. Okay? See what I just did? I did it myself. So focus on the behavior and not the person. This is really important too, especially no matter who you're talking to. Instead of you are late checking your sugar, sugar still needs to be checked. You didn't pack your supplies. Supplies aren't packed yet. You forgot your lancets. Lancets are still on the counter. So this is really important because people get defensive when you are accusing them, when you're letting them know that they have failed to achieve what you're expecting of them. And so really focusing on the behavior, and it sounds a little like passive conversation, and that is okay in this context. Sugar still needs to be checked. Supplies aren't packed. Lancet's still on the counter. Points to the behavior, not an accusatory way. So how to get started? I think I alluded to this. You are a school nurse or a parent of a child, or even in a pediatric care setting where you are interacting with adolescents. Just really letting them know, as I said earlier, that this is my role, and sometimes I'm going to have to put on my coach or facilitator hat to help. But tell why this is important and express your caring and concern, and that you realize they need to learn to take care of themselves. And that's important to you. And that's why you have that role. Additional tips for yourself. These are persons in development. When we're talking about adolescents. They're not strengths and weaknesses. Okay. They are strengths and areas for improvement people. So be aware of your writing reflex, be aware of what you do when you get afraid, because I know personally as a parent with a child with a pretty serious chronic disease, growing up with helping manage that and building remarkable self-management with her. She's just amazing even to this day. I really learned early on that my fear got in the way. And until I really started recognizing what I was doing when I got afraid, because it's usually not pretty. It's usually not constructive. It usually does more harm than good. So I had learned to train myself just to pause, even just for a couple of seconds, and think before I blurted something out. That takes discipline and a lot of practice. I will encourage you on that. So let them make some small mistakes within reason and experience the consequences of that. If you're hovering and trying to fix everything and keep things from going wrong, that can be very problematic in them developing their own independence and feeling empowered to do so. So decide to be an encourager. We're going to praise everything that we can within reason. If you overpraise, it's going to sound shallow. But decide, I'm going to look for things that I can encourage. I will tell you that most kids learning to manage type 1 do better in structured versus unstructured routines. Help them form habits by tying tasks to something they're already doing. If you've never heard of BJ Fogg's Tiny Habits, I encourage you to Google that. He's got his own behavior sciences lab at Stanford, and he's funny and brilliant. He actually was a general session speaker at ADCES annual meeting a couple of years before the pandemic, and just awesome. He's all about tying tasks that we're trying to change to something that you're already doing. Also make time for yourself. Getting depleted makes you less effective. And I would say that goes for parents as well as school nurses. I remember one time walking into my grandson's school. He was in 3rd grade at the time, and I had something I needed to talk to the nurse about in regards to him. I was co-parenting with my daughter when she was in pharmacy school, and her husband was in law school at the same time. So the boys were staying with me at least a few nights a week. So this was not that long ago. And I remember starting a conversation with her, and I was saying, do you have a few minutes? She said, sure. I just got finished, seeing, talking to 80 different students. I think she was exaggerating. But the point I'm making is I could tell she was kind of depleted. And I think that all of us can find ourselves burnt out in these encounters. So also find friends and support for yourself and for your child and teen. So I have included here some references. The one that I really want to recommend is the book I've put in blue at the top. A lot of what I developed with this, both for my projects and my research and my dissemination of all those materials and trainings, is really wonderfully informed by Nar and Suarez's book, Motivational Interviewing with Adolescents and Young Adults. Highly, highly recommend this book. Talks about a lot of different behaviors, including some related to what we're talking about here, but they just really hit the ball out of the park with the way they handled that. So before I engage this, I am going to ask you what questions you have for me, but I also want you to know I put my email address here because I do encourage you to feel free to email me at any time. I love to hear from people after things like this, any questions or any other things that you might want to do. But so what questions do you have for me? I think I just have a few.
Thank you, Jan. This was great. So if anyone has questions specifically for Jan, the questions that are in the Q&A right now are actually about last night and some things that they heard. I don't know if you, happy to read it. I don't know if you'll be able to answer it or not. And Alicia might be able to jump in here and answer. But last night it was mentioned more than once that the school has a responsibility to provide the nurse with a device to pick up type 1D CGMs. Another school nurse and myself would like to cite that rule to the individual schools where we each work to provide them with this instruction that they must. So either you or Alicia, do you know the answer to where they can find like actual like law or text that says they need to provide that?
Okay, I do not, but I will tell you this. During my time as president of ADCES, ADCES was working with the School Nurses Association at the national level and developed this great resource for school nurses. And I know they're not the only ones that have something like that, but it goes into a lot of this. I know things have evolved since 2022 that year. I think it was 2022 or 2023 that ADCES came out with that. And I think you can probably get that from the website. I don't think you have to be a member to be able to get that. So that might answer a lot of questions like that. Or Alicia thought.
I'm kicking myself because I have it on my desk in my office, but I didn't get into office today because we had a lot of ice. But I know what is now Breakthrough Type 1, formerly JDRF, has a advocacy resource and a school resource. And their school resource toolkit actually has a page that cites the federal mandates, the federal equal opportunity mandates and the federal ADA mandates. Both of which cite basically that like our speaker was saying last night, that we as people with type 1, as students of any school that receives federal funding, because disabilities are covered by the ADA, we're entitled to equal opportunities to education. And therefore, and that our medical rights can't be withheld from us. And so that what is then required is of the nurse to extrapolate and explain to the administrators, because then they're then explaining to we're now the medical expert explaining to the non-medical personnel. So we then have to explain to them that we can't deny medical treatment, AKA the CGM, because it is standard of care especially for pediatrics. And cite that's in the 2025 and 2024 guidelines. And then to cite that that we also then can't prevent these students from having equal opportunity to education, and to prevent them from having care, prevent them from having safe, effective hypoglycemia treatment would be preventing them from having education. So it's just pulling those two kind of sources together. There's not necessarily, now different municipalities may have on their books that children may have devices for That's going to vary municipality by municipality, even administration by administration, district by district. But on the higher level, and we all know that federal law is going to trump any local statutes anyway. So being able to pull those three mandates together is going to give you what you need to then take to administrators. And then, you know, to give why they should then pay for you to have a school provided device, well, then it's just clearly HIPAA. If it's on your personal device, that's not a secure, encrypted, coded, locked down device. The school has a responsibility to make sure to protect student data, just like they have to protect it when it's in the front office and they have that student's date of birth, they have that student's medical information, they have that student's social security card number, they have parent financials in their, you know, lunch line, finger scanny, all that stuff now. My gosh, I'm a parent of an elementary school child. My mind is blown. But they have to then protect all of that info. So they can't do that on this glitterific iPhone that I carry around with me every day. So they have to, the legal burden then falls on them. So when you put that in front of their legal team, they're gonna fork out the money for the cheapest. I mean, it doesn't even have to be an iPad, and we're just talking Dexcom. It can be an like a 6th generation or newer iPod. So it's literally like $200-300. It's not a massive investment. So.
Awesome, thank you. And while you were chatting, people were putting in the Q&A some links. So I dropped those into the webinar chat that take you to the ADA's website. They're PDFs. So those will certainly help as well. Okay. May a school nurse text a parent or guardian with health information regarding their student? Does this violate HIPAA or FERPA? And she said it depends on what device the school nurse is using to text. School nurses may use official devices such as work provided phone, iPad, or other smart device.
And even then, be careful, because texting, like if it's just like iMessage, if it's not end-to-end encrypted and it gets caught somewhere in the middle, and then somebody sells little Jimmy's information on the dark web, like now you're stuck. So that's one of the services I'm gonna show today is encrypted end-to-end. So I recommend using something that you know is encrypted end-to-end. So otherwise, make a phone call, because now it's never it's just never in writing. So if you've got to transmit PHI, doing it verbally, that way you know it's not it's not in print, so it's harder to steal, is good. If you need it in print, then make sure it's encrypted end to end.
Okay, awesome. Well, thank you so much, Jan. I don't see any other questions about your topic. I did drop your email into the chat, so if people have follow-up, they can reach out to you.
Okay.
Awesome.
Well, thank you so much for having me. I
Thank you.
enjoyed sharing some thoughts with you tonight. Best wishes to everybody.
Thank you for being with us.
Bye.
Bye-bye. All right, Alicia, you're up.
All right, let me set up my sharing. There we go. Well, thank you everyone for sticking in after our long work days. We are going to dive in on care coordination. We're going to echo a lot of what we've already heard from our other 3 speakers, because that's kind of what care coordination is. It's taking all of our pieces and really pulling them all together. So I got to get my Zoom bar out of the way. My Zoom bar just sat right on top of my presentation. There we go. Maybe. There. Don't want to mute myself. There we go. And so this is a little kind of rehashing of who I am. Few things I wanted to point out. I do live with type 1 diabetes. I am Director of Patient Care and Education at Integrated Diabetes Services. I am really, really fortunate to work for a practice of diabetes educators who all also live with type 1 diabetes. So I get to take what I learn as a person with type 1 and share it with other people with type 1. to hopefully make their journey a little bit easier than mine was. I'm also a mom of a 7-year-old with ADHD. So I'm coming at this talk tonight as an RN. So I come in and go, okay, I know how hard I worked for this license, and I know I need to stay within my scope of practice. You're not yanking my license, and I don't want to end up there, testifying if something goes wrong with this kiddo. And I know everybody's looking at me. And I also know that being in the school setting can be unbelievably isolating because everybody else here is a teacher or an administrator. They're not a clinician. That's just me. I worked for 6 years before I became a CDCES. Sorry, new verbiage. It's been years and I'm still getting used to it. But I worked in behavioral mental health, and kind of similar to a school building, because everyone was either an administrator or a therapist or a support person. I was the only nurse in the building. I was the only, well, we had a psychiatrist in the building, but they're a different breed. If somebody's broken a leg or having a stroke, you don't want the psychiatrist to come running. People, but different breed. So it was very isolating at times. It felt often like I was kind of going rogue a little bit, and so it was a little daunting. But I'm also a mom, and I've been on that first 504 IEP OMG WTF meetings where I'm just like, I just want my little boy to get through his educational experience well. I want him to get what he deserves, to level the playing ground so that he can learn and safely and well and effectively. I'm a foster and adoptive mom, so I know that not every kid is coming in with what they deserve to come in with. And some families are barely what we can call a family. Some of these kids are really, really struggling just to survive. Some of these kids getting into our presence is the safest, healthiest, most nurtured 8 hours of their day. And the reality is that, we're just trying to get insulin in these humans. We're just making sure they have insulin for the week of spring break when they're not here. So, the priorities of one family with diabetes and another are going to be massively different. And what one school nurse is living through and what another school nurse is living through is going to be massively different. And one school nurse is going to be worried about a kid sneaking Snickers after Halloween and their blood sugar going to 400, and that's the biggest concern in the day. And another school nurse is worried about the kid who came in with type 1. We just found out she's pregnant, and that's going to be a whole other level. So like, I get the span of what you all are dealing with, and I cannot even, I'm really glad I don't have to deal with it. I have experience in all ages and stages of type 1 across the US and around the world. And apparently I can't spell Cecil County, typo-a-palooza, but I am from Cecil County, Maryland. I know we have a lot of Delaware nurses here tonight, and I love you guys. Nurses and teachers in Delaware are my peeps. So many of my besties are nurses and Delaware teachers. I feel like I was looking down the participant line and I was like, I feel like I know a lot of these names, and I probably do. So if you know mine, give me a shout. So we're going to briefly touch on emotional responses. A lot of our speakers and Anna did a great job with this yesterday, but it's so important because when we're looking at coordination of care, we're coordinating the student and the caregivers and also other clinical personnel and school staff as well. And especially in diabetes, the emotions are so high and can be so much of the barrier. My personal take on diabetes management is that diabetes, especially type 1 diabetes, but all forms of diabetes, diabetes is a medical diagnosis. It's made by our doctors, it's made by our physicians, and we get prescriptions and it goes through our health insurance to deal with that. But it really is a medical diagnosis with a mental and behavioral health treatment plan. Because it's not just the doctor writes a prescription and we take the med, and if we take it twice a day for 7 days, we get better. Because we don't get better. It's chronic lifelong disease. It is in fact a chronic lifelong terminal disease. We can manage it, but if we stop managing it, it will kill us. If we don't do what we have to do, we will die. Chances are the first line on my death certificate will say diabetes. If not the first line, the second for sure. I could get hit by a crosstown bus and it's going to be like vehicular trauma secondary to looking at her Dexcom. Like they're going to find a way to make it about diabetes. And that is a massive mental health piece, but also just managing it. The average person with type 1 diabetes makes something on the order of 180 additional decisions in their daily life that has to do specifically with type 1 diabetes. If it's the parent of someone with type 1 diabetes, it's probably 2 to 3 times that, because we all know that a parent never just makes one decision. It's always you make the decision and then you rethink the decision and then you act on the decision and then you rethink whether you made the right decision about the decision. It kind of never ends. And blood sugar touches everything. And blood sugar is then affected by everything. I sat down and tried to think of anything, any biological function or psychological any activity that doesn't impact my blood sugar. And there isn't one. It all moves because every physiological function in my body is powered by glucose. It all takes ATP to run it. And that all comes from glucose in one way or another. So this thing touches everything. So we have to start there. I keep hitting the arrow. Oh, let me do that. There we go. We have to think again of the grieving process. And Anna did a great job touching on this. The one thing I would add is to remember that especially in kids, we often see a delayed grieving process, because if a child is diagnosed at 4 or 5 years old, they don't know what they don't know. As far as their experience of life in the world has taught them, every kid at 4 or 5 years old goes and gets diagnosed with type 1 diabetes. They're very plastic. They're very resilient little humans. And so they just run with it. So it may be when they're 8, 9, 12, that we also have a very self-centric model of the world. So we don't really look around and realize like, oh, other people have a different experience of life than I am having until later on. And then it can hit, then the why me, then the I'm angry, then the I'm gonna not eat all day so I don't want to take insulin all day, the bargaining, then the depression of that I can't handle this anymore and I'm starting to burn out can start to hit. And the initial reaction can easily be like, it's been, you've dealt with this for years. Why now? Can be our natural sort of gut instinct. Like, or there must be something else going on. It couldn't be the diabetes. The diabetes has been around for years, but now it's kind of coming to roost. We can also see kids have disruptions because they were supposed to be forming maybe physical autonomy when they were 3, really breaking that physical autonomy from mom and dad. The toilet training was really settling in and they're dressing themselves and really, but here came diabetes. And now all of a sudden somebody is coming and getting in their personal bubble and laying hands on them and doing shots and doing finger sticks and putting juice in their mouth at 3 o'clock in the morning every day. And so that physical autonomy really got interrupted. And so now here's that same kid at 10, 12 going to their first slumber parties and really having adjustment problems there. So we can see a lot of delayed kind of things going on. So some kids developmentally kind of might have weird hiccups along the way. And so we might see sort of skills or skill sets that a kid that otherwise developmentally completely normal might kind of hiccup or stutter step or regress somewhere weird, that we might have to think like, oh, well, when were they diagnosed? Where might that now be rubbing up against what they're dealing with now? And again, thinking, where does that really conflict with their goals of their developmental stage? Their healthy developmental stage goals might be in direct conflict with what we're asking them to set as their goals for diabetes management. So we might be asking them to step out of class and come to the nurse's office when their developmental goal is to be like everyone else. And we like to talk a lot in our society about being an individual and I'm my own person. But the reality is a student between the ages of about 8 and 80 wants nothing more than to blend in with their peers, and who they are as their sense of self is very much being built by their peer group. And so asking them to step out from their peer group regularly is going to have a major impact. So right there, we're kind of setting up for some coordination barriers. So how do we understand these diverse goals of these diverse populations and bring these complex, sometimes disparate goals into collaboration? Well, we always start with the student, right? Because the diabetes is in their body. We have to, beyond anything, we have to respect the physical integrity and autonomy of the individual. That is paramount. And we have to realize that we are teaching these students to have their own self-respect for their internal and physical integrity and autonomy from the first moment they step into these schools. That is actually, as school nurses and as health educators, the most fundamental and important thing that we can teach students. No one is going to care about their weight or their cardiac health or smoking or their nutrition or skin cancer risk if they don't have a strong sense of the importance of their internal and physical integrity as an individual and autonomy, that they have both the right to determine it and the ability to determine it. Without that, we live in a state of constant victimhood and hopelessness. And the reality is a lot of our students come from that. A lot of our students come from a space where someone else tells them what to do, what to eat, what to wear, when to sleep, when to wake, where to be. Why? Because I said so. Why? Because you're smaller than me. Why? Because you're of a certain color. Why? Because you're of a certain economic class. Why? Because you're diagnosed with diabetes. Why? Because you're overweight. Why? Because you're female. We have to recognize that you might be the first person in their life that looks at them and says, your body, your call, kiddo. And if we tell them that it's their call, that means that it's their call, whether or not they have high cholesterol, whether or not they're overweight, whether or not they have hypertension, whether or not they have skin cancer risks, whether or not they get a colonoscopy when they're 50. When we're setting the stage for them to be an empowered individual. So we have to respect that. We have to teach them how fundamental and important that is. So we have to start with, hey, kiddo, you first. What are your goals in school this year, this semester? Chances are their goals are not to rock diabetes management really hard in the 7th grade. Now, you might find a kid who does. I definitely have patients where their primary goal is a flat line, is 90% time in range. And honestly, when I see that, I make their goal for their diabetes management to find a better goal than diabetes management, because developmentally that's not terribly appropriate. I'm digging into some what's going on there. But I'm going to support that student's goal. So then I'm going to take note of that. What's their primary goal? Okay, what's their secondary goal? Where does diabetes fall in their goals? How can I support their goals? Because, okay, social growth. I mean, I'm probably not a huge part of that as your nurse. I'm cool, but I'm not that cool. I'm decidedly skibbity toilet. Definitely Ohio. Very Elriz. So that sentence proves all of that. But safety, probably also decidedly low priority for most kids. Occasionally you get the kid who's probably a little anxious and safety creeps up the ladder pretty high. When safety's a little higher, okay, I can come alongside with that one. I can not only work with you on that one, I can work with you on that one until safety starts to come down the ladder a little bit and we can move some of the other ones up. And then okay, safety, social engagement, academic growth, great. That I can help with. Where do you think diabetes might come in conflict with your academic growth? Oh, if I have to leave out of math class, or, oh, check it out, math class comes right after lunch. If my blood sugar goes to 250 after lunch, I'm not going to be able to think. Or if it drops to 60 after lunch, I'm not going to be able to think. Great. Let's see how you, me, mom, how can we care coordinate to strategize the crap out of lunch so you're not going low during math class. We're going to wrap diabetes into the goals that this student already has. Care providers. I say care providers because I am a foster adopted mom. I never know what a care provider looks like. So care provider here, grandma, auntie, foster mom, state facility, mom, dad, whoever that looks like. Care providers are more likely to prioritize diabetes management and safety than the student, but it doesn't mean it's their primary priority. It could still be academic growth. It could still be social growth. I definitely have parents who are like, I don't care if their A1C is 9. I want her to be the captain of the cheerleading squad. Okay, cool. Between social and athletics, that's your priority, mom. I hear that. We might need to have a discussion as to the health and wellness of that decision and how these things are going to conflict with each other. You can't be the healthiest athlete if your A1C is 9. So we might need to do some stratification adjustment. One that we need to keep an eye on here is that parents often misjudge that there has to be a stratification. We can't say, I want it all. Nah, that's not real. We have to strategize. I will often I'll draw out Maslow's hierarchy of needs for parents, and I will explain to them that we have to recognize your child can't be trying to be the world's best scholar and the world's most amazing social butterfly if their body is struggling to function. We have to make sure their body's feeling okay. So, we can't try to be all things at all times. We have to give a priority to these. And let's work together to make sure that we can give a priority that's going to be most effective and healthy for your child. And I always check the child's priorities first, because then I can sit down with the caregiver and say, these are your priorities. Here's in terms of the hierarchy of needs, where your priorities are going to rank. How can we look at these and your students' priorities to support them as best we can? A, your priorities are going to shine through if we do those two. B, you won't have an uphill climb on your hands if you're supporting their priorities, because then they'll flourish. And then we have our priorities as the clinician, as the school nurse, as the school supports. Obviously, we're looking at safety first. We have, coming from our administrators, a massive litigious burden. That's the real nuts and bolts of why we're in a school, because we have to have these children in a space that's not built for children with compromised medical situations, right? And so how do we shore that up so that we don't have kids in danger and massive lawsuits shutting down schools left and right? Well, we slap a nurse in there. That'll do it. It's no pressure, right? So, but do we see the massive opportunity for massive conflict here? That we have a student with one set of goals, a caregiver with another set of goals, and then a school system and supports with a different set of goals. And so bringing those and coordinating those is definitely going to be tricky. Identifying and aligning those goals is essential, though, for diabetes management, because obviously if we're all working towards different goals, we're just going to be rife with conflict all the time. The nurse is going to be going, well, we have to stop the hypos, and the parents are going to be going, but we have to stop the highs, because she has to be the best academic that I've ever seen. And I read that in studies, if blood sugar is over 200, the conversion from short-term to long-term memory is impeded and recall is impeded, and she's never going to be the straight A valedictorian that I want her to be. And then the kid's going, but I'm 7. I just want to be JoJo Siwa when I grow up. So no one's going to get anywhere in that conversation. So we have to be able to say, okay, how do all our goals align? How can we bring them together? So instead of a tug of war, we can actually all coordinate and work together. So how do we get in some strategies and some tools? Well, communication is going to be super, super key. We've been looking at how do we do that. I'm going to bring some tools in a moment. But again, fostering unified purpose is really, really key. Setting goals collaboratively. So we're going to start by going, okay, what are everybody's goals? And then we're going to sit down and we're going to use a lot of we language, and not just we language. We are going to mean it. We're going to say, we need to work together to reduce hypos. We need to contact Joaquin's prescriber. And then we're going to team up. We're then going to split up the work burden. We're going to say, can you please place a call for the next 2 days? In the next 2 days, I'll follow up with an email, call, or message. So I'm not saying the doctor needs to do something, because that's passing the buck. And the parent goes, yeah, no kidding. The doctor never does anything. Why do you think we're in this mess? And I'm not saying you need to call, because the parent's like, yeah, that among the other 9 billion things I need to do. We need. And I'm saying, I'm going to ask you to do a thing, and I'm going to ask you to do a thing in a certain amount of time, because this is the other thing that I'm going to be doing. And you need to do your thing, because my thing doesn't work unless you do your thing. And now the parent goes, oh my gosh, I'm going to do the thing because that nurse has my back. I'm going to do the thing because the doctor's actually going to respond, because somebody with letters behind her name is going to do the thing. And that's the other thing. I always tell the parent, you do this thing because then I'm going to follow up and I'm going to put my letters behind your name. I tell parents that all the time. I'm going to put my letters behind your name, but you have to call. Otherwise, I'm just the crazy nurse who's calling, trying to bully the doctor. You make the call. I'll put my letters behind your name. We need to put our heads together to help you find a good strategy. So this is like with the student, and this works. It doesn't work. It doesn't matter if you're talking to a kindergartner or a senior in high school. We need to put our heads together to help you find a good strategy to remember to take your insulin in the morning, Stacy. Let's brainstorm ways that your family can make better use of the school nursing office as a resource, so I can lend my support too. So what I'm not saying is, Stacy, you got to take your insulin. Stacy knows that. Stacy's not stupid. Stacy was there at the hospital when someone told her if she didn't take her insulin, she'd die. That's a pretty easy to get message. Stacy's maybe in denial, but she's not an idiot. What I'm saying is and then I'm saying, Stacy, you have a family. And even if your family is a train wreck, you have the school supports, and you have me. I'm here. I'm reminding Stacy of that it's a we. This is a team project. And I'm saying, if you can't remember to do it at home, what I'm soft saying is bring it here and we'll do it here. But I'm not saying that. I've just set it up. I've just lobbed that one up in the air. I've left it for Stacy to say. So I've said, make better use of the nursing office so I can lend my support. I've just lofted it up in the air. Let Stacy say, well, then can I bring my insulin here and take it? Oh, fantastic idea, Stacy. Absolutely. Anytime you can do that, loft an idea up and let them knock it out of the park. I love to be the nurse who almost came up with the great idea. Offer it up there, loft it, almost. Like put almost all the pieces in place. Fantastic, especially anybody age 7, 8 and above. Almost give them the idea, give them all of the pieces, and then let them give you the idea. You don't have to sell anybody. Repeated low blood sugars are scary for all of us. So this might, like a mom, he's low every day he's having low. They're scary for all of us. We can work together to spot times that are leading to them, and how we can work together to help all of us live with diabetes with more confidence. What we're saying is we're telling them, yes, this is scary. I am hearing that you're scared. And I'm seeing that your student is scared. And it's not a picnic for the teacher is scared. It's nobody wants something to happen to your kiddo. If something were to happen to your kiddo, that's a nightmare that nobody wants to deal with. Let's all work together. Let's find the pattern. Not so that the lows don't happen anymore. That's saying the lows are a problem. It's what the goal is so we can live empowered and confident and not under the pressure of this fear anymore. Identifying support needs for the individual. Again, emotional support. Individualize our strategies. Understanding clinical orders and goals. Clinicians are like doctors, endos are really not in the driver's seat when it comes to diabetes management. Like I said, it's really a mental health model. Diabetes is managed day to day, hour to hour. So it's really the caregivers. It's really the person with diabetes once they take on more and more of their own management. I have had, I do remote consultation, and I have had 12-year-olds pop up on the other side of the Zoom, and I do the entire appointment with the 12-year-old. And I send the email to the 12-year-old and the parents, so the parents are in the loop, but the 12-year-old does the entire consultation. The best thing I've ever heard was when a 12-year-old who once told me, oh yeah, that low blood sugar, that was dad. He's screwed up. And that's why I went low. It made me so happy. The vast majority of the families I work with actually request that I not send updates and information to their prescribers. They update their prescribers on what they are doing with their insulin. I can tell you, as a person with diabetes, my prescriber does not tell me what to do with my insulin. I inform my prescriber what I'm doing with my insulin. So it's crazy. And that leaves us as nurses with our tail ends hanging out, because like, no, I need a doctor's order to change what's going on with this kid's insulin world. That's how it has to work. Otherwise, I'm outside of my scope of practice. That's why I put all of these fancy letters behind my name so I could do insulin adjustment without flying that half mast over here all the time. But when you're looking at, and you're also trying to get, well, okay, this is the student's goal for their management. This is the parent's goal. What's the doctor's goal for this kid? When the doctor signs off on DMPs, diabetes management plans, or 504s, and that's going to give you some indication. So if you're looking and like, wow, this kid's target range is like 100 to 250, that's high. Might be a kid who's been hospitalized for severe hypo, and the doctor's like, I don't even want to see them anywhere near a 55. Or, the other side, target range 60 to 140. Oh, okay. Wow. Oh, we're doing some extra tight things here. What's that about? That it could give you some indicators. Maybe they've got a really intricate way of dealing with exercise. Or maybe it's just throw 30 grams of carb before every PE and cross your fingers. If you need to, reach out to the doctor, especially if what you're hearing from mom is we keep everything really tight and right, and we really avoid anything over a 200. And what you're hearing from grandma is we really avoid a low. Lows are unacceptable. Lows are so scary. It doesn't matter how high we go as long as we don't get a low. And what you're hearing from the kid is, I just bolus for lunch and the system takes care of the rest. Translation would be great. I might want a little clinical clarity on what is this kid's world actually looking like. So reach out, especially in those in-between times. First beginning of the year, probably not a great time to reach out to clinics because they're going to be slammed. But middle of the school year, middle of the summer, great time to reach out to their clinic. So some great tools for this. Some great tools for care coordination. I love Blue Loop. Blue Loop is a free, it's an app. It's an app for parents. Nurses can get on the app too. Most nurses will use the desktop version. It's got a bolus calculator. It's got a caregiver app. It's got CGM and SmartPen integration that all feeds in. It's all HIPAA compliant and encrypted. It's EHR integrated, so it'll connect straight to the doctor. It's got you can have multiple student profiles. Families who have multiple kids with type 1 can have multiple child profiles. It's got all-in-one messaging and charting. This thing is crazy robust. You can log in it. It's really amazing. I really recommend you check this out. Because like you can have a student has a high blood sugar, you put in, high, unexpected high 400, check for ketones, trace, drank 12 ounces of water, returned to class, changed infusion site, send message, text goes to dad because that's his preferred method, email goes to mom, and a note goes to the EHR to the doctor's office. And it's recorded in the Blue Loop platform. And, at the end of the week, you want to put it in the student's chart that the school uses, print out a PDF report on the kid and then stick it in if you need it in paper, or just, save it and put it in their digital, however it works. It's really phenomenal. There's a video link down there if you're grabbing screenshots. I was going to play it, but I don't want to use up the time tonight. There's an app or a platform for that. Integrated apps are the thing. There's one here that I really like, especially for parents, but also if you are in a situation where, kids are sick, kids with type 1 diabetes, especially, they're going home. Like somebody needs to come get this kid, because sick days can go from I don't feel good to medical emergency pretty quickly because of risk of DKA, risk of severe hypo if a kid can't eat. The sick day app is great. You enter in blood glucose, ketone presence, appetite, and it can give guidance on what to do to prevent DKA. So, we've all had that situation where, you've called the parents 3 times and nobody's picking up their phone because everybody's in, whatever situation they're in. And little Susie's been sitting here puking her guts out for the last 2 hours and she's got type 1. And you're like, my brain's glitching out on what I'm supposed to do about this. This app could be really helpful. Classroom management. This was one that I was referring to yesterday. People are like, how are we supposed to have these kids in the classroom with their phones because they need their Dexcom and their pump app, because now all the pumps are being controlled by apps on phones, but on the Wi-Fi, but not like texting and on, I don't know, Twitter box, face. I don't know what the things are because I'm old now, playing games and sending nudes and whatever shenanigans these kids are up to. My gosh, I can't. Things like app block and block site are fantastic. These are secondary apps that can be put on the phones, and they are basically, you give permission that only certain apps are available. They can be set that only certain apps are available during certain time frames, or some of them have where only certain apps are available when the child is in a certain GPS radius, which is amazing. You can say, okay, you're within so far of the school, you can't access these apps. Or they can be accessed only by a code that's on someone else's phone. So, okay, you want to get on chat face, you have to ask for permission, and then a message goes to mom's phone and mom has put in the code, or it goes to the nurse's phone and the nurse has put in the code. I like that option because we do live in a world where things happen. And I can foresee a time, because we have these cell phone bans, and that's great. I come from a world where you weren't allowed to have phones or pagers in school because everybody knew that meant you were a drug dealer. And now my son goes to school with a smartwatch, because I'm paranoid because his mom's a nurse. So, but it's got an app on it where I can lock down everything but certain features during certain hours. But I could foresee a situation where there's an active shooter and the kid with type 1 diabetes is the only one who can make a call out because he's the only one with his phone. So, him being able to say, mom, can I have access? There's a shooter in the school. That could also be life-saving. So those apps are really, really cool. I feel like I missed one back there. Oh, I did. Where'd it go? There we go. If you have kids that are on pens, and especially a lot of kids are on pens, especially post-diagnosis, InPen is the best smart pen we have. I definitely recommend get them on the InPen. It really helps with cross communication and care coordination, because all the data goes into an app on a phone, and all of that data then goes directly to, for example, Gluco, or Blue Loop. So, you don't have to get the text that says, Joaquin got 3 units before he got on the bus this morning. You can just pop open Gluco. The other really great thing is when all of these things are linked together. If you get access to that kid's, for example, Gluco, and their Dexcom goes to Gluco and their pump goes to Gluco, or their pen goes to Gluco, or Tide Pool or what have you, you can see that info. You can just pop it open and see, because all of these things Bluetooth feed and Wi-Fi feed into this thing. And, we all know some of these parents don't get their kids to their appointments. Sometimes just getting to these endos is near impossible. And if you miss the appointment, you get bumped another 6 months out. But you're having a problem. You really need orders for this kid's basal insulin to get adjusted. You have access to these reports now. You can pull them as a healthcare provider and send them to the doctor and say, please, I am looking for an adjustment. Can we look at an adjustment to this? Send what you think would be good, what you're looking for. Send it to that provider and say, please, for care, seeking care coordination. and be the starting point for that. I don't know a single pediatric endo that won't get back to you. I don't know a single PCP that won't get back to you with help. And you're going to be cleared by HIPAA because you're a healthcare provider seeking care coordination from another one, but you can also pull up your own HIPAA allowance, communication allowance form, and have your parents of kids with type 1 approve you to send those reports over, and you can really help that family out. Establishing roles and responsibility, establishing clear roles at the beginning of school years, right on diagnosis. This is critical. I'm gonna breeze through this because our 504 education was really, really good. One thing I like to really give us all as support is right in the middle, that school nurses are not responsible for managing diabetes. I repeat, not responsible for diabetes management. Time and range is not the responsibility of the school nurse or school supports. No more than treating cancer is the role, or treating pneumonia is your role. Responding to acute illness onset or emergency exacerbation of chronic condition, just like you would a child with asthma or epilepsy. Too often parents are like, but my kid's spending too much time high. My kid's spending too much time outside of range. That is a problem between you, your kid, and your provider, not your school nurse. That's not our job. My job as a school nurse is not to make sure that no child here gets athlete's foot or a cold, or that every child here is perfectly moisturized. Like, optimal wellness is not the function of the school nurse. I wish it was. The fact that y'all do like vision screenings and check these kids' teeth, and it's amazing. I mean, once upon a time, it was just like, do you have scoliosis and rickets? Like, you're going so far above and beyond already that parents get this idea that you're like in-house medical everything, but you're not, and don't feel that you have to take that on. It really is just response to acute situations for student safety. And honestly, when we pan back, yes, it's for that one student's safety so that they can attend school. It's actually for all student welfare, because if Jamal flatlines, none of the other 20 kids in class can get an education either. Like, that sounds horribly cold-hearted. And as a mom and as a person with type 1 diabetes, it's like, how could you possibly say that? But that is the reality. We have to make sure all of these kids make it to the end of the day, not just this one. So you're not there for management. Okay, so the student's primary role is to learn, right? That's their job. They're also responsible for their own physical safety, for their safety awareness and that of their peers. They're responsible for their own hygiene. Now, if they can't fulfill those roles because of, maturity, ability, emotional stability, those can ebb and flow. And that's where, if they can't fulfill their own personal safety needs, that's when we're looking at, okay, do we need a one-to-one situation? Do we need a para in the classroom? Do we need to adjust our staffing ratios to accommodate student needs? Community providers, so the doctors outside the class or the school in the community, their insights are into medication management, dosage adjustments, treatment plans. Some tips here. Prescribers, again, take a very back seat. When we're looking at having prescribers write orders, I recommend that we have them written as broadly as possible to allow room for effective care coordination and growth of student autonomy. When I look at my son, he is a vastly different human at the end of the school year from who he is at the beginning. If he had type 1 diabetes, I would have to have orders rewritten 4 times to adjust for a kid who can now do different levels of math, different levels of reading, different levels of comprehension, different levels of memory. Every time we had a med adjustment on his little ADHD butt, we'd have to get a different 504 written up if we had really specific orders. The phrase poor per caregiver guidance, as long as the caregiver has sufficient knowledge and safe guidance skill or safe diabetes management skills, that phrase is going to allow the caregiver to then make insulin dosage adjustments, to then make adjustments to diabetes care or diabetes management plan, self-care tasks, and how trips are managed, how sports are managed, things like that on the fly on an ongoing basis. And then that can just be documented through something like, text, download them, print them, whatever needs to be done, or something like Blue Loop, however you're capturing that documentation, just like you would a verbal order. Make sure you repeat it back, that it's nice and clear. Sign off on it like you would a verbal order. Boom, you've now got that documentation, because the doctor basically has, word that just fell out of my brain when you hand it off, not designated, the other word that someone's going to put in the chat. Shut down because it's after 8 p.m. That we're allowed to do as nurses. Delegated. There it is. Someone has delegated. The doctor has basically delegated that care. They've used their clinical judgment to safely delegate it to the care provider, who has been effectively educated. Woo, there we go. Important conversations, again, to have before. We've already been over those. The when, hows, by whom, a big one that was pointed out. When are we going to contact? For what? And to whom? Yeah, we don't want to be figuring that out halfway through the school year and contacting 3 people and then having 3 people with 3 different opinions on what to do reach out to us. That's a crap show. A big tool as well as contract for care. If a contract for care is essentially a list of if-then SMART goals, specific, measurable, achievable, realistic, and time-specific goals with a set of essentially reward and consequences for each of the parties involved. These are fantastic for students, as well as between school support nurse and student, school support nurse and caregiver and student, parents and kids, spouses, people in relationship, everybody. I love contract for care. We are taught these in nursing school. In a hospital, the contract for care is a given. I am in a hospital. The contract for care is that I am your nurse. I am going to come and provide you with assessment, treatment, education, support. You are going, if you are compliant with those, you expect to see no deterioration, hopefully improvement in your condition and so forth. And we've got this relationship. We don't necessarily have that in a school, right? We're in this weird kind of limbo land. So when we have trouble, when we have like, okay, we need to see things change. We got a little bit of a struggle here. We need behavioral change. We need diabetes clinical outcome change. A contract for care is a great way to do that with students, and it works from little bits all the way up. So some examples, say we've got Jane, and this was one that came up yesterday, and Jane's driving home, but she's struggling with hypoglycemia during her school day, and maybe even on her drive home, she's had some lows and she's really scared people. Maybe she had a car accident or near it. Maybe a contract for care would be a really great tool. So we're going to build a contract for care that says Jane will always carry hypo treatment and glucagon on her person through her school day. Why? Because she has type 1 diabetes. She's on insulin. That's just baseline care. All people with type 1 should do that. Jane will not override recommended bolus calculator boluses by more than 25% without adult clearance during the school day. So we've identified probably a cause of why Jane has been having more hypos than she should. Jane will report to the nurse before driving from school. If BG below 100 or IOB indicates BG likely to fall below 100 per bolus calculator intake per bolus calculator, comma, intake recommended carbohydrates. So that would be part of her diabetes management plan, how we're going to treat or head off hypoglycemia. If Jane has 4 consecutive school days without a BG below 70 during, she does not have to report to the nurse before driving home from school and may treat her own BG according to number 3. So we have set some requirements for Jane, but we've also put a carrot. We're not putting stick, we're putting carrot on this one. We always want to use carrot first, especially in diabetes management. That way we can celebrate wins. So if she goes 4 days with no hypos, that means she has achieved number 2 and number 3 successfully. So we haven't needed number 1, or she's, eating her glucose treatments and not going low. She's knocking these 3 out of the park. Number 4 builds in a win for Jane. And so hopefully number 1, 2, and 3 happen more and more often. So number 4 happens more and more often. So now we can, and then just like any plans, time specific, we're going to have a time to reevaluate and adjust. Heads up, if you've got kids who are really type A and they're really on it, or kids with ADHD, you're going to have to rotate these suckers out pretty often, because kids who are really type A are going to blow through a challenge really fast and be ready to move on to the next one. And they're probably going to blow on to the next one, but then the first one will fall off. So they'll need to circle back to it. So they might have to have a few challenge points that they kind of rotate around. Kids with ADHD, on the other hand, will not be motivated by the same thing for very long. So like that, getting to go to school without checking in with the nurse will be a big deal for like a few weeks, and then it'll fall off. You'll have to find anything. Care coordination, burnout prevention. I always find as a nurse, nursing, I could do all day. Care coordination will kill me inside a month. Like, care coordination is crushing. Building those 504s is crushing. One other thing on care planning. I love if you can get mental health supports, school counselors, guidance counselors, anybody else in on those too, especially when they're student to caregiver based. A lot of times we're trying to change a behavior and we're not going to, because the problem stems from home. And so we need to get somebody else in on that. But yeah, I find once I'm doing 504s, once I'm trying to work with doctors, it's just so crushing. It can absolutely just demolish my want to. So remember, you are a caregiver too. Engage with the type 1 community in real ways. Get involved in walks, get involved in education, get involved in Breakthrough T1D, get involved in your local clinic, in supporting the community. Our moral and ethical responsibility is first to our students. Moral injury is horrible for nurses, because there's what we know that we morally should do and what we ethically should do. And then there's what the people who are signing our paycheck tell us that we have to do or that we should do. And the wider the distance between those two things, the wider the moral dissonance, the more likely we are to be injured psychologically, emotionally, and spiritually by that. And it's really damaging. So being aware of that and really coming back to you and coming back to working with a therapist, coming back to you, coming back to having people to talk to about that and recenter on that, doing good self-care, keeping up with education so that you don't feel like you're out of your zone, out of your space where you feel comfortable. And again, remembering your why, knowing why you are a nurse, why you're a school nurse, so that center again, when you're faced with these really tough times, that we can do a lot of what. We can do a lot of hard what if we remember our why. So thank you guys again. Thank you as a person with type 1. Thank you as a mom of a kid who's been on the other side of the 504s. Thank you for hanging in, for taking your time outside of your workday and after your long workday to be here. And I am here. I am now at your disposal. If I can keep speaking English, I'm at your disposal for questions.
Thank you so much, Alicia. This was fantastic information. And I think there's a lot of good takeaways that they can put into active like tomorrow. So couple questions here. What is IOB?
Oh, I'm sorry. Insulin on board. Sorry. I speak nurse and I speak diabetes, not realizing that everyone isn't bilingual.
No problem. All right. Thank you. Thank you. Awesome. Susan,
My
oh, go ahead.
email was up there. My email is, I'll throw my email up in the chat as well. Feel free to reach out to me for any resources, any questions, anything. So
Great. Susan had mentioned earlier, actually, I think before Jan even hopped off, that she's used the readiness ruler, and it always amazes her how kids do not hesitate to give her a number promptly.
oh yeah.
Okay, thank you. Yeah, the slides, so the recordings and the slides will be put on the coalition website, and I'll be sure to put it links to those in the emails. I know a lot of you are having email, the emails are hiding, so please check your spam folders, your promotions folders, your junk folders. And if you're still not getting things, I've been forwarding the last night's eval to people. So I can certainly do that. I am going to put the link to the eval in the chat before we get out of here. So if you stick around and just use that link, then we won't have to worry about email as much for the eval part of this. Email to get in. Okay, I think that's it. No other questions. Just a bunch of thank yous.
Awesome.
Thank you so much, Alicia. And, feel free, you'll be on our mailing list now. So feel free to join us in the future and get CEs for yourself.
Absolutely. Thank you, Sarah. This is a great program.
Thank you. Appreciate it. All right, here comes the survey link in the chat. Be sure to grab that. I'll leave this open for a few minutes just so people can get there, but I'll shut my screen off and everything. But Alicia, thank you again.
Thanks, everybody. Everybody have a great night, and thank you again for all you all do.
Bye-bye.